Hi, good evening to everyone. I'm Dr. Philip McMillan. I have been focused on autoimmunity since early 2020, and this new information in this paper is fascinating, looking at the complexity of autoimmune responses that are starting to occur. This is some breakthrough information that has come through from the UK, in Yorkshire specifically, about an unusual pattern of disease that they are seeing. You really want to see this. It's a complex presentation. I'm trying to break it down as best as I can, but you need to be involved to see the trajectory of disease that we're likely to be seeing over the next few years. This is the paper that I'll be focused on, and it was published just in May 8th, 2024, and it's talking about MDA5 autoimmunity and interstitial pneumonitis. This is lung disease. So I'll be going through that in just a few minutes. But yes, just to start off, before we get into this, just a reminder to everyone, we were number one. We need to get back there on Amazon. Listen, we waited a bit to raise the awareness about this upcoming. Well, we've done the book launch. We were number one. Now we have the paperback version available coming up tomorrow on the 14th of May. And so we want you to get involved. The link is below. You could go directly to Amazon as well. But if you join us here, if you wanted the hardcover, it's not available on Amazon. You would have to register with us and then we'd be able to send it to you. So we are pushing forward to help people understand a little bit more about nitric oxide. And this is Humming Hero's beautiful images and story to just capture people's attention over time. So join us in that journey. Additionally, coming up in a few days' time, depending on when you're watching this, is COVID vaccine benefits and risks, shot of hope. This is part of the ongoing plan or course, Advanced 360, where we're looking at COVID vaccines objectively, looking at what worked, what didn't, why didn't it work, what are the mechanisms. You can join us. Some of the tickets are free. And so if you're interested, please sign up early. It's all again linked to our course. This is part of the pre launch sale. This is a huge course. We're already over 30 modules and growing. And so if you want to join in early, please do so. We cover every aspect of COVID 19. This is the plan to get you educated. So let's get back to this issue of dermatomyositis, the outbreak. In the first place, what is this? Now, you have to remember that this is primarily an autoimmune disease, a dermatological manifestation of disease. So it usually is managed by rheumatologists or dermatologists in order to manage the condition. And I've got here a little summary of it. And this is from NetMeds. I found this was quite good. It's firstly rare. It's an inflammatory disorder. It affects the skin and the muscles. That's where the myositis comes from, dermatomyositis. And it's like an inflammatory muscle disease, myopathy, with skin rashes and muscle weakness, usually in older age groups, but it can occur as well in children. And so it's a relatively rare disorder, and it stands out because it has some characteristic patterns around it. One of them is to do with the skin rash. You can see that there is the skin rash here and this heliotrope rash around the eyes. That's a very unusual pattern that you see in dermatomyositis. They don't know the cause of it, but it's linked to some genetic predispositions. And critically, as we said, the skin discoloration and inflammation, including the purple and red rashes with itching around the eyelids, also on elbows, knees, chest, and back, weakness in the muscles, and in some rarer cases, you can have breathing distress, shortness of breath. That's the lung pattern of disease. So, what had stood out was a very important paper that I said came out of Yorkshire, where they were noticing an unusual pattern with the disease. So, what happened is that this is what they call MDA5 autoimmunity and interstitial pneumonitis. Once you see that, that just means that the lung is inflamed. Itis means inflammation. and it spread right throughout the inside or the interstitial region in the lung, and it causes the lung to get very stiff. It's kind of fibrosed, and this causes problems. And you can see most of the authors here are, this is Leeds, well, somebody from Israel, Wakefield. So they have quite a number of people involved from the Yorkshire region. And I've highlighted here what they found is that essentially, as we said, it's not very common, but if you have anti MDA5, which is melanoma differentiation associated protein 5 involvement, it tends to cause a rapidly progressive interstitial lung disease with high mortality. That's what caught their attention. And so they were looking back over the period of time between 2018 and December 2022 in Yorkshire, looking at the clinical features. What they found was that there were 60 new cases, and few of these, only 8 of the 60, had a prior history of confirmed COVID 19, and the peak rates overlapped with regional SARS-CoV-2 community positive rates in 2021. And also, 58% of the 60 had received COVID vaccines. Now, I find this very interesting because very often we have found that these papers are afraid to talk about the potential link to vaccines. And so often they would just say there is no evidence that this is linked. Finally, the scientific community is not trying to make that determination. They are just giving us the facts. The facts are that in this case, of the 60 cases, 58% of them were vaccinated. Now, that may be coincidental. We don't know. And that's the kind of thing that needs more research. I've highlighted here as well the implications, the potential risk of developing this entity after mild infections and its contemporaneous with vaccination suggests the potential emergence of a distinct but rare form of the disease. So, again, they are connecting the two. One of the mistakes we have is that a lot of people, they're either one side or the other. It's not black and white in this. Infection causes a number of things. We know there is a relative risk increase with infection causing autoimmunity, 42% relative risk. So we know the SARS-CoV-2 virus, especially as I've said, it's a viral mediated autoimmune disease for severe disease. It makes perfect sense. You will see increased risk of autoimmunity. What had happened, however, is that people don't want to acknowledge as well with increased risk of autoimmunity. As I've mentioned before, in a small study in Italy, they found a 20% absolute risk. Now, you have to remember, infection was relative risk 40%, 20% absolute risk increase of new autoantibodies after vaccination with mRNA vaccines was quite significant. Sadly, that hasn't been replicated at a bigger scale, but what it means is that both can cause autoimmune responses. And when you add to that, that the vaccination doesn't prevent infection, it may reduce it temporarily. Therefore, you have a double hit phenomenon in that people who even may have mild infection could then go on to develop more autoimmune problems. And this is what this could link to in order to make it make sense. So let's go into a little bit more detail in terms of what they saw. So this is from the paper again. And as I said, the reason they did this study was because they observed a significant rise in this type of dermatomyositis. So, meaning that there are all kinds of autoantibodies associated with it, and you can see them all here. All of these are the different kinds of autoantibodies that they can see. But the one that stood out as increasing the most was MDA5. This was a red flag. So, this is what caused them to look in more detail. When they looked at the new MDA5 positivity rate, when they looked at 2018, I guess this is out of the whole cohort of patients, 1.2% is what the rate was in 2018. 2019, it was 0.4%. In 2020, you can see this fits with infection, autoimmunity. It increased, so it almost doubled from 2018 to 2.1%. But in 2021, goodness, 4.8%. And so this is almost a 4 times increase from 2019. This is when we started to do vaccination. And then in 2022, it came down again to 1.7%. So it's still higher than 2019, but not as high as 2021. And this is part of the reason why all you can say is that there is an association, but it's not definitive that the cause is infection or vaccination, one or the other. I think it's a combination of the two. The immune system could be primed through vaccination, and then on even mild infection, it reactivates or triggers an autoimmune response in some individuals. That has been my working approach in looking at autoimmunity in terms of triggering diseases. And when they did a bit more detail, when they looked at this rapidly progressive lung disease, so they said 40% of those with positivity also had interstitial lung disease, of which 48% either developed progressive interstitial lung disease or died due to the rapidly progressive disease. So out of the 60 cases, 35 of them had no interstitial lung disease. Only one of them died. But of the 25 who had interstitial lung disease, 8 died. 4 are progressive, 13 are stable on steroids. And so this is pretty serious stuff. And you can see that they've managed to stabilize some of them by using steroids. I've just mentioned just how important steroids are in terms of autoimmune and inflammatory disease. So it's a really, really critical piece of our approach to the work around inflammatory and autoimmune disease. Now, the question is, why is this occurring? Now, this was shared with me. Somebody, I've forgotten who it was. I wish I could give them credit for sharing this paper with me. But this paper then raises the question, why? What could be the mechanism? Why is it that this MDA5 could be involved? Now, in the paper, they highlighted that MDA5 is critically linked in the context of the way how the virus evades interferon. And so, because MDA5 is part of that interferon trigger, and we know that the virus targets that, it's possible that because the virus targets this, it was able to then trigger or exacerbate this autoimmune response. And so this is probably, I have here this image that they have come up with. They think that the viral infection gets in the lungs. This is the normal response to produce interferon, but the virus tries to inhibit this response by inhibiting MDA5. And MDA5 normally picks up double-stranded RNA, would be the virus. It would trigger an interferon response, which would then warn other cells. The strategy of this virus is to block interferon. So it's possible that somehow the connection between the two leads to an exacerbation of an autoimmune issue. And that's the presumption in terms of infection. The question is, what would be the presumption in terms of vaccination? That's an important question. Now, what I've done is, because I was thinking about this, I went and looked back at this paper. This was an important paper, review of N1 methyl pseudouridine, friend or foe of cancer. And it was looking at the mRNA vaccine, which uses this instead of uridine to get around the immune system. Okay. So this is what I'm going to use to show what I think, and this is just my opinion, what I think is potentially the link with regards to vaccination and why we would see this surge, a 4-time surge in 2021. This is from the same paper here. Now, what it's showing you here is that the RNA in the context of trying to get to make protein, in order for it to evade the immune system here, it has to inhibit these two proteins, MDA5 and RIG1. Because if these are triggered when the mRNA of the vaccine gets in, it will destroy it, and it will do the job of triggering interferon and therefore stop the whole process of it being able to be produced. So part of the challenge that they had to come up with is that this is why they use this methyl pseudouridine, is that this was then able to evade these, allow the cell to then make lots of spike protein and trigger the immune response that leads to the antibody production. This is part of the reason why they also think in this paper why there could be an association as well with cancer, because it could interfere with this whole process by the fact that mRNA has to evade the immune system. But the critical thing that stood out for me here in dermatomyositis is that MDA5 also has to be evaded by the mRNA. And it seems possible that some overlap in that evasion is potentially the cause as to why we would see this kind of growth of a disease. So what I then thought about is, well, if it's MDA5, what happens to the RIG1? Could you also see autoimmunity to that? So this is what I was just looking at just before the presentation. And I did find an interesting paper here. And so this paper here is looking at RIG1 receptors and type 1 interferonopathies. And it's looking at diseases that would be triggered by this other receptor that also would block the virus and also block the mRNA from making lots of proteins. And in the context of inhibiting interferon, both of these would be a risk. And so when you look at the type of diseases that come up from this, I'm just trying to find it in this paper here because I'd looked at it before. They were looking at a list of autoimmune diseases that they would suspect would be associated with it, including SLE, Graves' disease, multiple sclerosis, rheumatoid arthritis, psoriasis, and in immunodeficiencies like IgA deficiency. They also notice an association with type 1 diabetes as well in the context of this particular one, which is to do with RIG1. So based on that assumption with the involvement of these proteins, you can anticipate that it won't only be dermatomyositis that's increasing, but other autoimmune diseases that grow. Now, let's get to the meat of what I want to focus on. This paper mentioned the point about could it be linked to vaccination? And it didn't just say there was 58% positivity, they gave us the data. That's what I'm interested in. Let us look at the data and try and make our analysis ourselves. So here is the supplementary online materials looking at the information that they were using. And this is very important. You'll see it at the bottom of the paper to find the supplementary online materials. So what I then did is I've captured here so that you can look at it yourself, is I've captured here the exact breakdown as to what it was that they saw. So let's look at that here. This is where they looked exactly at the age, sex, ethnicity, past history of autoimmunity, COVID vaccination, COVID infection, and then this is to do with the characteristics of the disease. What I was interested in was this bit here with regards to COVID vaccination. So I'll make it a little bit bigger so you can see it with me. So when we look at this person here, 48 years old, 7 months after, he had no prior history of autoimmunity. This person 3 months after being vaccinated, no previous history of autoimmunity. This person 2 months after, no prior history of autoimmunity. You can see that this person had it 4 months before. Let's just make sure we've got that right. First dose was 7 months after. This person was 4 months before. 2 months after, there was a background of hypothyroidism. This person was not vaccinated. 2 weeks before, and you can see as you run down, you can see this is where the 58% of patients being vaccinated came from. And you can see how many of them had no prior history of autoimmunity. A few people had Graves' disease, hypothyroidism. Some, as I said, were not vaccinated. But as you roll through all of the cases, you can then see the pattern that is developing and the characteristics that are there. So this is the kind of research that we need being done. It doesn't mean that the vaccine is the primary mechanism, but I do suspect that it's part of the mechanism. And the way that I describe it is that it's more along the line that the infection can trigger it, but if you have infection, vaccination, then infection, that significantly increases the risk of autoimmunity. And this is why we need to find ways to prevent this virus from circulating. It is putting the whole population at risk. This is one of those times where I can happily end off with the fact that the elephant in the room was mentioned, it was discussed, it was focused on. This is where science needs to go. We don't have to know exactly the mechanism, but just acknowledging the elephant in the room is huge progress and something that we should all be very happy about. Because at the end of the day, if there is an association, the earlier we know, the earlier we find out and understand, the better it will be for everybody, well, at least all the patients, and we will be able to find solutions, hopefully, to make a difference for others. So, again, thank you for joining me. Remember, look in the description below for the links to the upcoming webinar, the links to the Humming Heroes, and the links to the Advanced COVID 360 course. We look forward to sharing with more information with you in the future. Have a great evening.